All right, this is it. The final part of our series on acute vestibular syndrome. We're putting everything together to build the complete bedside framework. We're going to show you how to confidently answer one of the toughest questions in emergency medicine. Is this patient's vertigo just a benign inner ear problem, or is it a life-threatening stroke? Let's dive right in. So let's kick things off with what might be the single most important and frankly counterintuitive idea in this entire series. This concept pretty much flips our usual medical thinking on its head. In almost any other situation, a normal test is great news, right? It's reassuring, but not here. In acute vestibular syndrome, a normal head impulse test is a massive red flag for a stroke. We're going to break down exactly why that is. So this is the core dilemma we face at the bedside. A patient rolls in with AVS. They've got constant vertigo, their eyes are beating with nystagmus, and they can't walk a straight line. Here's the problem. The symptoms of a benign inner ear virus, vestibular neuritis, can look identical to a life-threatening posterior fossa stroke, and it's our job to tell them apart, quickly and accurately. Now, this is a huge statement, but the evidence absolutely backs it up. In that first 24 to 48-hour window, a small stroke in the back of the brain can actually be invisible on an MRI, but a well-performed HINTS exam can pick it up right there at the bedside. This is just a perfect example of why your clinical skills are your most powerful diagnostic tool here, not just rushing to get a scan. So, how do we crack this case? The answer is a structured three-step bedside exam called HINTS, and it stands for Head Impulse, Nystagmus, and Test of Skew. Now, this isn't just some random collection of signs. It's a validated set of tests designed to systematically check the vestibular pathways for any evidence of a central lesion. So let's break down each of these three components. But first, remember the golden rule, okay? For this exam to be considered reassuringly peripheral, all three parts have to point to a peripheral cause. Even one single central finding changes the whole game. Okay, first up, the head impulse test. Now, with vestibular neuritis, that vestibular nerve is inflamed. So the vestibulo-ocular reflex, the VOR, it's broken. So when you turn the patient's head, their eyes drift off the target, and then they snap back with this little corrective saccade. That is an abnormal test, and it's actually reassuring. It points to a peripheral problem. The really worrisome finding is a normal test. If that VOR is intact and there's no saccade, it means the peripheral nerve is working just fine, which strongly suggests the problem isn't in the ear, it's central in the brainstem or cerebellum. Next up, we look at the nystagmus. Now, peripheral nystagmus, it plays by the rules. It's horizontal and its direction fixed, which means the eyes always beat in the same direction no matter where the patient looks. It also gets worse when they look away from the bad ear. The central red flags, though, they're unmistakable. If you see nystagmus that changes direction when they look different ways, or if you see any nystagmus that is purely vertical or torsional, those are always central signs, period. And finally, we have the test of skew. All you do is cover and uncover each of the patient's eyes, and you're looking for any little vertical shift or misalignment. This skew deviation, as it's called, is a super specific sign of a brainstem problem. If it's just a simple peripheral neuritis, this test will be totally negative. And this is the most crucial point of all. You could have an abnormal, reassuring head impulse test, right? But if that same patient also has direction-changing nystagmus or a skew deviation, the exam is positive for central cause. Any single worrisome feature makes the entire HINTS exam a red flag for stroke. There's no mixing and matching here. One bad sign spoils the bunch. Now, the HINTS exam is incredibly powerful, but it's not the whole story. There are several other critical red flags that demand you immediately escalate to imaging, no matter what the HINTS exam shows. These are the absolute stop what you're doing and get a scan signs. So if your patient with AVS has any of these, the bedside evaluation is over and you move to imaging. A sudden severe headache or neck pain, that could be a dissection. Any new focal neurology, like a facial droop or slurred speech, that's a huge alarm bell. The inability to even sit or stand up without help, that's one of the strongest predictors of a cerebral or stroke. And sudden hearing loss on top of vertigo, that points directly to a stroke in the AICA territory. Okay, this is a critical clinical pearl. It is so tempting to just order a quick head CT, right? But a non-contrast CT is notoriously bad at picking up acute strokes in the posterior fossa. I mean, the sensitivity can be as low as 10 to 30% in the first day. A normal CT scan gives you a dangerous false sense of reassurance, and it should never, ever be used to rule out a stroke in a patient with AVS.
Okay, so we've done the exam, we've identified the pattern, and we've checked for those big red flags. Now what? Let's put it all together into a really clear management plan. How do our findings actually translate into action? This flowchart maps out the whole process. Think of it like a fork in the road. If you have a crystal clear peripheral pattern with 0 red flags, you can head down the green pathway. That means symptomatic care and outpatient follow-up. But if you have a central pattern or multiple red flags, or even if you're just not totally sure, you must follow the red pathway. That means an urgent MRI, a neurology consult, and admission to the hospital. When in doubt, you image and admit. It's that simple. So let's just summarize these two very different pathways. If you have a confident HINTS peripheral diagnosis, the goal is all about symptom control, getting the patient moving early, and referring them to vestibular rehab. But if you have a HINTS central picture, the goals are completely different and much more urgent. Activate the stroke pathway, get neurology on the phone immediately, and admit the patient for management. Two totally different worlds. Whew, we have covered a lot of ground. So let's just boil this all down to the most critical, high-yield points that you can take away and use on your very next shift.
If you remember nothing else, please remember these 3 rules. 1. A normal head impulse test is the dangerous one. 2. Big red flags like being unable to stand, they trump everything else and mean you have to get a scan. And 3, a completely 100% unequivocally peripheral HINTS exam is the only time you can confidently diagnose vestibular neuritis at the bedside and think about sending that patient home. And that concludes our 3-part explainer on acute vestibular syndrome. You know, the single most important message through all of this is that in AVS, a structured bedside examination isn't just an option, it's absolutely essential. It lets you stratify risk way more accurately than early imaging alone, and it empowers you to catch the dangerous strokes while safely managing the benign cases. We really hope you found this AVS series valuable for your clinical practice. To keep learning with us and to get access to more clinician and patient resources, please visit our website at australiandizzinessclinics.com. And hey, if you found this useful, we'd really appreciate it if you'd subscribe and leave us a rating. Thanks so much for joining us.